Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. And today we're going to be talking about medications and medications and sexual dysfunction. So I have a special guest, an expert. Her name is Dr. Rachel Rubin. She is a board-certified urologist, a fellowship-trained sexual medicine specialist, a researcher, and a director at large for the International Society for the Study of Women's Sexual Health, ISSWSH, and has her own practice in Washington, D.C., and she's been featured in many, many media outlets, including NPR and the New York Times. What an honor to have you on. Thank you so much, Rachel.
Thank you for having me. I've been following your journey. I admire you on Twitter from afar, and I'm so grateful that you're here and doing this work.
Thank you so much. Well, I am so interested in hearing about your journey, how you went from, urology to now your own practice in sex med, and you treat both men and women, correct?
Yeah. So very few people, what people don't understand is they expect their doctors to be like ChatGPT and know absolutely everything. And I'm here to tell you that your doctors don't know absolutely everything. And so we expect our gynecologists to know everything about women's sexual health, and you expect your urologist to know everything about men's sexual health. And it turns out they don't. And it's very disappointing. But after my urology training, I then did a fellowship in something called sexual medicine. And so I learned to dive deeply into treating people with sexual health concerns and issues. And it's something that not a lot of people do. In fact, we have about 27 fellowships and growing for men's sexual health. And there really was one, and now there's a couple more starting programs recently, but really there actually is only one that acknowledges both men and women together. And so again, it really is this comprehensive sexual medicine training that there's really only a handful of us in the country who do it to the level that we do it. And so I started my own practice. I've been in practice for a long time, but I started my own practice 2 years ago, and it has been the joy of a lifetime to spend a lot of time with people and really dive deeply into sexual health concerns. I joke, I always say I'm Dr. Rubin, sex detective, right? You come to me with a problem, and we're there to really get to know you, to figure out what are your goals, what do you want, what is a success story for you, and how can we use our toolbox to get you there.
That's amazing. So I know you're a rare find. I met you at ISSWSH at one of the conferences. And it's funny, I had Samina on another episode, and she was talking about how it's like a cult. Like once you discover this avenue of medicine that's been underserved, you just can't get enough. So I love that. And yes, it is kind of shocking how little attention women's sexual medicine gets. And I've heard that you have patients coming from around the country.
We actually have patients around the world. We have patients in from Greece and Italy and England and Germany and all these places. And not a day goes by where I don't get an email internationally from someone saying, do you know anyone in England who does this? Do you know anybody anywhere around Europe? It really is so frustrating how much work we have to do to train people to do this at a high level, right? Because it's not just, oh, I heard this lecture and it was interesting, but how do I get people to write the prescriptions and do the procedures and have the time and the space to really connect with people? Because that's really what it takes. It takes really sitting down and getting to know someone and saying, okay, what's your story? What's actually happening? What's going on in the relationship? What's going on with your anatomy and biology? And like, how can we optimize it for you and your partner or partners, right? How do we optimize it to live your best life? And that's really what we do. And it takes time to do that. And unfortunately, medical system in the United States is not set up to give you the time that you deserve.
That is so true. Yes. I mean, whether we have like 15-minute appointments, how much can you really do? How much?
think about yourself. Like your life, right, is worth so much more than 15 minutes once a year, right? It's worth that. It's worth more. People are deliciously complex. I love humans. Like I love the human condition. I'm obsessed with people and their stories, and they're so interesting to me. And then you add relationships, which makes it a whole other dimension of fascinating. And it is that curiosity that drives me to want to do the work. Now, the problem in medicine is we think, oh, as soon as you start talking to people, you must be a therapist. You must be a mental health person. And I will tell you, mental health professionals are amazing and wonderful, but they don't know how the biology of your penis works. They don't know how the clitoris functions. They don't know if there's a problem with the genitals that is affecting your ability to live your best life. And so we have a problem here because there is a great divide between the doctors and the clinicians who talk to you and those who are just looking very, very closely only at one part of you.
Yes. I mean, that just ties in so well with why I wanted to talk about this, because, these short visits that we have with patients, not deeply learning about their lives, kind of promotes this culture of a quick fix and in the terms of medications. And we certainly have that sort of culture. People are on a lot of meds. That's kind of why I want to talk about it. They're on a lot of meds. They have a lot of side effects. Some of them, in fact, very often they have sexual side effects. So I thought actually what you were saying about spending time talking to your patients, learning about them, just sort of reminded me like we should spend a few moments talking about the psychosocial model of sexual response, or sex, because I think that's something fundamental to understand. It's not just like something quick to treat. There's a lot of different elements. So do you want to spend a few moments sharing your thoughts about that?
Oh, I have so many thoughts on that, right? And it's so important that people, I think one of the major things that makes me good at my job is that I really want to educate the person in front of me about what's going on with their body, right? The more I can arm a menopausal woman or a perimenopausal woman with just how the body works and how hormones work to the level that we understand it today, the more they become empowered and the owner of their story and the advocate, where they get to decide and choose what tools they want to use in our growing toolbox, right? And that is the magic, because when a patient comes in, like you said, just fix me, doctor, just tell me what to take, it never goes well. It's not the right approach, right? But the more I can educate, and give people the language and the words about how their bodies work, then they become so interested, and then they understand the biopsychosocial approach. They understand that if they are not safe at home with their partner and they're walking on eggshells, that they're not going to be able to relax enough to have a great orgasm with them, right? That's not going to work so well, because orgasm is a buildup and a release of tension and requires like a really nice synchrony between your fight or flight response, your relaxation and your tension. And that takes work in biology. And so again, the more patients understand, the anatomy behind sexual health, the more they can say, oh, actually, Rubin, I want to try that pill. That sounds really cool. I would like to see, I know it might not work for me, but sure, let's give it a try. And so medications are not all good or all bad. They actually play a big role in the work that we do, but it's the education that's the magic.
Wonderful. So how big a problem is this? And do you think it's increasing, decreasing? Is there just a certain base level of sexual dysfunction that's just,
let's just say I don't think I'm going to go out of business anytime soon. And if I trained 1,000 people, I still won't go out of business, because it is everywhere, right? So sexual dysfunction is extremely high. And as we get older, right, because there's so much biology and our bodies are changing, then sexual dysfunction is going to increase, right, as we get older. And then we add, the psychosocial stuff. And of course, it's going to be a big problem. And so the really important thing is, if you're bothered by it, if it bothers you, it deserves medical attention by someone who knows what they're doing. And understanding, like we said, doctors aren't trained to do this, care about this, know about this. And so there's a lot of doctors are not so good about saying, I don't know. I actually think one of my magic powers is saying, well, we don't know, there's no data for this. Medicine hasn't figured this part out yet. But doctors have a hard time saying that. So instead, doctors have decided, oh, we're just going to tell the patient it's all in their head and that they're crazy. That's going to be our response because I'm a doctor. I must know. If there were an answer, I would know it. It's wrong. So again, like it's so common. Sexual dysfunction is so common, but the key is bother, right? If you are bothered by your erections not working, or you are bothered by your lack of arousal or lubrication, or you can't orgasm and want to, you deserve to see a specialist, just like you would if you had a heart condition or cancer or something like that. The problem is finding the specialist. And sometimes that's why we have so many people travel, because finding the specialist who's going to take the time and really dive deeply on what society views as a small problem, right? Society views the clitoris as a very small very small thing. Whereas someone with a clitoris problem, it's a very big deal. It's a very important thing, not only to them, but potentially to their partner. And so when people come to see us, it's about what you value, not what society values. And so if your libido is a driving factor in why your marriage isn't working so well and you want to address it, that's a big problem in our books. Nobody waits 6 months and travels across the country to see me for a small problem. So, whereas society in a 10-minute visit says, oh, you have a low libido? Well, there's like people after you have cancer or having babies, like those are real problems, lady. Get out of my office, right? Your libido deeply matters and it deserves medical attention, but sometimes you have to find the space in the room where it can get that proper attention.
I love that. I mean, I very much am always bitching about the patriarchy, and that's very much my view, is just that women's sexuality is repressed, but also like women's sexual health concerns or women's sexual health is just not paid attention to. It's sort of considered not a big deal, but it is a big deal. I mean, we know that how important it is for men. I mean, it's a crisis if you're having sexual health problems as a man. Everyone recognizes that. And we should recognize that it's also a similar level of importance for women. Like it's normalized too much, right? Like, oh, you're menopausal, it's just normal.
And let me paint, I'll paint this picture because I think it's helpful because I take care of men and I deeply love helping both sides of the couple, because if we're just helping one side, we're actually hurting the relationship quite a lot if you're only helping one of those people. And so I actually give a great lecture where I'm always asked to talk about women's sexual health to men's health practitioners. And I say, we're killing men because we're not taking care of their partners. Because men who are divorced, single, or widowed have worse health outcomes across the board. Worse cancer, mental health, just longevity, they have horrible outcomes. So as a society, we should be promoting this idea of keeping people together. Well, when do marriages fall apart? Around perimenopause, menopause, and what causes marriages to fall apart? Often sexual issues, right? We're not having enough sex. That he wants more sex. His libido's too high. It hurts her, or things like that. So if we could invest in both couples and in discussions about these issues, think of how many relationships we could potentially save, which would keep men living longer. It's kind of crazy if you think of it that way.
I mean, you just made a light bulb go off in my head. I'm like, we're treating men's sexual dysfunction so well, and they're raring to go, but that's often just at the same time when women are having decreased libido, decreased orgasm, just decreased desire. So that's wild.
Pain, right? Like they have pain, which is just like it doesn't matter how hard the erection is. If if it's a female partner and it's painful, what are we doing, right? What are we doing?
And fixing an individual's problem increases the couple's problem. Wild. Thank you. That is really, really kind of a revelation for me. I often am mostly thinking about women.
And this is the problem, actually, right? Because we are trained, the gynecologists are trained just to look at the women. The urologists are trained just to look at the men, although they are trained to take care of women. They're just not as good at it, unfortunately. Yes. And so we actually miss what is called the homologs, right? We misunderstand. So all the things that happen in penises happen in vulvas because they're the same thing. But because no one's looking at both of them, except for a handful of us, and we don't have a lot of funding and research money and things like that, we're missing a huge opportunity to really help people.
Yes, you're a rare bird. I mean, we need more doctors like you treating both. Is your practice about even, do you think? 50,
So
50?
it's funny. It's probably because my social media is often very female focused because women are on social media and love Instagram and things like that. I would say it has turned to about 70-30% women, men, but we're growing. I mean, the men want to come in. There's just no spaces for them. So that's why I'm working really hard to bring in more clinicians, train them to this very high level and be able to help more people because my model is spending time with people. There's only so many spots.
Yes.
And so I have a lot of problems and challenges about how to create that access, how to help more people, because it is that individual time that is the magic. And that's the challenge that we have in our practice.
I mean, I get the impression that most urologists are like seeing 90% men. So, and you probably in your training saw so many men. So, it sounds like
we love it. We love seeing men.
Rare.
We love our male patients. There's no question, but certainly there are not enough people who are helping women at this level.
And I think a lot of us doctors listening to you are going to be very jealous of how much time you get. You probably spend an intake time of like an hour, I bet.
Well, it's an hour in person. It's an hour and a half. And I'm actually about to grow it to 2 hours because even an hour and a half is not enough time because the education piece, right? If you're going to listen to someone's life story and then educate them on the biology of what's happening in their bodies and then do an exam. Are you kidding? Like an hour and a half is not enough time even for that. And so I find again, this idea of like really having time with people so that you can do the education piece, because it doesn't matter how much I know. If that education isn't really deeply getting into the patient's brain, it doesn't matter. I failed as a doctor. So for something very simple as vaginal hormones to prevent urinary tract infections and make sex not painful, right? We know vaginal estrogen fixes pain with sex, prevents urinary tract infections, helps with urinary urgency, is safe for everyone to take, literally everyone to take, no matter your history. And yet, if my patient doesn't understand it, they will not fill the prescription. They will not use it. They will not get the benefits of it. And that's not them being non-compliant. That's me sucking as an educator, right? And so that education piece is so important, and we're not doing enough of it.
Oh, I'm so jealous. I'm so jealous right now because yes, I think most of us who go into medicine, who enjoy being doctors, are people persons. And so you do want to get to know people and really get to the root cause. In some sense, we are a bit, therapists, I think,
I'm a psychourologist and you're a gynecologist, right? Like that's what I've heard.
I love that. Okay, so and I love teaching. I mean, because that, just like you made the light bulb go off in my head today with that point you made, I love seeing that deep understanding on the patient side. And you're right, like writing a prescription, it's these days, like people don't want to just take a prescription. They know there's a lot of side effects. And when you understand how it's going to work for you, there is going to be better compliance. That's such a good point.
Yeah, I just had I was late to this podcast. I just had a patient who's going to have surgery. And this patient has a complex history, right? With a lot of stuff going on. And we just sat in the room for an hour and I have a TV screen behind me with a PowerPoint presentation. And I'm going through, here's the anatomy, here's what we're going to be doing, here's the process, here's the good, the bad, and the ugly, right? And knowing that you have a lot of other stuff going on, I don't know that I'm going to fix all the things. And so here's what I think it will fix. Here's what I don't think it will fix. Here's what else could be going on with you. And we should look at X, Y, and Z. And this is a person who wants to go to med school one day. And she's watching this and so grateful for the knowledge, the anatomy, the looking at it. And then we did an exam on her where she has a mirror and I'm showing her what she just saw on the diagrams. She's seeing on her own body, right? She's just with clothes on. She's looking at the diagrams and the PowerPoint on the TV screen. And then we do an exam with a mirror. And I say, remember that part that we looked at on the picture? Here's that part on you. You see how it doesn't hurt over here, but it hurts right next to it. That's what we're going to be doing. And it is that piece of it where now if the surgery, say, doesn't 100% 100% fix all of her problems, which, let's be honest, we know surgeries are not perfect, of course.
Right.
She now understands that I'm there with her. I'm going through it with her to say, okay, here's, this may still be a journey, and you have a whole team behind you who really deeply wants to figure this out, right? She is now educated, so she understands what could happen down the road. And that's magic, right? Like, it is just a win-win all around.
I love that. And I love what you said earlier too. Like getting the patients to understand how we're thinking and what we know. And what the thing that I really appreciated that you said earlier about how we are not gods. We don't know everything. And medicine will change. In 100 years, there will be other information that comes out. And so we can't answer all your questions, but I do love, what did you call yourself? A detective?
A sex detective?
I love that. Because that's basically what you're doing. And like, okay, well, outlining your approach with the patient, it's logical, it makes sense, it brings them on your side to work together, right?
And get them to do the detective work with you, right? I think that's also the key is that getting the patients to know that they're the CEO of their body, right? They are in control, and they're going to fill up their C-suite, right? So you're going to bring in a chief medical officer, and maybe you bring in a chief this officer. And if they're no longer serving you, they get to go and you bring in someone else, right? And so by having that ability to say, I am the boss here, and I'm going to get opinions and consults of people who are going to give me advice, but ultimately I get to choose. And Dr. Patel, I will tell you that when you give people information about their bodies and how they work, and you give them the toolbox, they make excellent healthcare decisions. It's not always what I would choose for my body, but it doesn't matter, right? They make excellent healthcare decisions that are informed. The disaster that's happening right now is that we're not giving people the right information, right? A 10-minute visit with your legs up in stirrups once a year is not adequate healthcare, and you're not being given the menu of things that you could choose from. And that's what we're fighting against. That's why I come on podcasts and I do social media and I yell and scream, because we have to reach people like more than 10 minutes once a year.
Yes, agree. I know this type of thing, it helps fill those gaps. So let's get into it. So what are the biggest culprits in terms of medication in causing sexual dysfunction in men and women?
Yeah, so we see a lot of big categories of things. Anything can cause sexual problems, right? So depression on itself can cause sexual problems for sure. So untreated depression can be a disaster for sexual health. We know, so the biggest category I would say is hormones in general. When you play with hormones, there are consequences, sometimes really good and sometimes really bad, but there can be consequences. So it's not as simple as all hormones are good or all hormones are bad. The answer is it kind of depends. So we know oral birth control pills have been shown in large studies to potentially come with lowered libido, some increased risk of sexual pain, and some increased risk of anxiety and depression. Now that data is kind of mixed, because when you have we love the idea of birth control and reproductive freedom, but when you use a contraceptive that alters the ovary's ability to produce hormones, especially testosterone, that may have significant effects on your sexual health. And so for some people, they're very sensitive to birth control pills when it comes to libido or sexual pain. We love things like IUDs, hormonal and non-hormonal, that don't alter your ovaries' function. And so we love vasectomies, by the way. Those are great birth control options. We love vasectomies. So birth control. Now, hormones we play with in men as well that can have devastating consequences. There's a medicine that many men use for hair loss called finasteride or Propecia that we see devastating, irreversible sexual side effects in some cases because of how it affects testosterone and dihydrotestosterone. And so we see a huge number of devastated patients who have those problems. So anything that affects hormones, things like spironolactone for acne, can affect testosterone levels. Things that can affect hormone levels can be things like eating disorders that can alter your body's own hormone levels. So anything that affects hormone levels can affect sexual health. Menopause in general can affect sexual health. I know that's not a medication. Now, other things, right? Sex is very dopamine driven, right? We have very dopamine driven brains. And when you go on vacation and you have all this dopamine, you've got great vacation sex and things like that. When it's new sex, right? That increases dopamine. So any medication or situation that can affect dopamine may affect sexual health. So the big category that we see are things like antidepressants. And so many of the SSRIs can help with sexual dysfunction, but also we see some lowered libido and delayed orgasm orgasm issues with different antidepressants. Now, there are some that seem to be a little bit less caustic, I will say, than others. And again, with all of these things, it's not universal, which makes it a little bit of Russian roulette because you don't know who's going to respond to which drug in which way.
Mm-hmm.
Other things, we see blood pressure medications can affect the blood flow. So we see some blood pressure medications affect erection in men. There's no question it affects arousal in women. We just don't talk about it. We don't talk about it as much. So these are kinds of the big sort of categories of things. Now, of course, non-medications, any kind of surgery, chemotherapy can affect hormone levels, right? So all sorts of things can really, really alter your sexual health.
What about, well, how does, like, for example, alcohol, marijuana, street drugs, do you have thoughts on that? What do you tell your patients?
So all drugs are a little bit different. So you can't sort of put drugs in one category. And there's some, actually, ISSWSH, there was an amazing talk one year sort of about different drugs and how they can affect. So interestingly, some people use substances to help their sexual health. And so when methamphetamine, for example, is like an incredible vaginal lubricating thing. And if you ask people on meth, much of it is really chasing this sexual high.
I didn't know that.
Yeah, like often sex is actually, there's a PhD student who all of her research is on meth and like rats to figure out, can we create the good parts about vaginal lubrication of meth and not the bad parts of meth? And so it's like very interesting of the substance can be very sexual. Again, alcohol is one of those things for some people a little bit is good and a lot is really harmful. And, so that sort of affects the brain and your ability to relax and things like that. Marijuana is very interesting because it's very hard to study in a very serious way because of the federal laws and things like that. But when you ask people and you do big survey data, it seems that marijuana is overwhelmingly positive for orgasm. And part of that is if you can relax and not get it, and calm down that frontal cortex a little bit, can that help you sort of be in your own body and experience that buildup and that pleasure? So I think each drug is a little bit different. Certainly, it's important to understand why you're doing different things and what it gives you and how we can create some of that sort of in other ways.
Interesting. So I had never heard that thing about meth. And I guess I want to tell the audience, like, we are not promoting meth use.
I'm not pro-meth. I'll tell you that. I'm not
on this podcast. But I have heard things about very positive things about marijuana as well. So and again, when we, it's really interesting as doctors. So I think you'll probably have a lot of doctors listening. When we went to medical school, right, we were told to ask patients, do you smoke? Do you drink? Do you do drugs? Do you have sex? Men, women, or both, right? Sex goes in the vice category, like it's somehow bad or dirty or like as bad as smoking. Like sex is as bad as smoking. And if you have sex with both genders, it's as bad as smoking. It's ridiculous. And so again, the more questions you can ask patients, the more you richly understand what their experiences are. So if they are using marijuana and you're concerned about it, or if they're using another substance and you're concerned about it, what do you get from this? What does it do for you? How does it affect your sexual health? Why are you doing this? Do you have any erection problems? Do you have any arousal? Do you have any orgasm problems? Right? Many of your listeners, I want you to think to yourself, has a doctor ever asked you about your sexual health? Like really asked you? Like I've never been asked, and certainly everyone knows what I do for a living, right? I wear a clitoris on my neck, for goodness sake. Me too.
So I know, right? So what if doctors were curious in the review of systems of like, hey, any libido concerns? Did it, do you have any questions about libido? Any concerns? How about orgasm? Can you orgasm? Do you have any problems with orgasm? Any concerns about orgasm? Arousal? Any problems? And when you dial it down, then we have tools in our toolbox to help with all of those things. But when we don't ask the questions, we then say, oh, they're on marijuana. They must be an addict, as opposed to, oh, marijuana is the only way she can orgasm. No wonder she takes marijuana. That makes sense to me. What if we help her orgasm in other ways, right? But we're not asking patients that.
Right. And yes, actually, my comment about the marijuana, that is what I've heard with female patients, but I've actually heard from partners about their male partners that it's maybe have a negative impact on their sexual function. What are your, I'm not familiar.
There is some research on that. I don't know where it's landed in terms of, I know they've looked at sperm counts and testosterone and things like that. And so I don't know the where it's all landed, but I know it's been looked at. Again, similar, it's difficult to study at a very large level because of the regulations and things like that.
Right. I mean, it's becoming legalized in so many places. It's legal in Massachusetts where I live. So, it's becoming a regular thing that, is positive on their when you take their history. So
Yeah.
I think we do need to study that more because it's going to be, it seems like it's used now, about the same or even more sometimes than alcohol. And to your other point about like doctors asking, again, that goes back to just how much time we have. It's hard to ask yet another interesting question that we would want to know. But when you're doing your annual and you have to do this whole checklist of things, did you get your mammogram? Do you have to do your PAP? Did you do your colonoscopy? Review of systems. And then to add another thing is opening a can of worms, which is sad.
And it's completely frustrating because if we deeply want to help our patients, the system is going to have to change, right?
Yes.
The system is not set up to give good medicine and good healthcare. And I don't have an answer. I can't, if I could fix the system, right, I would be in a higher up position. I have gotten myself out of the system because I can't play the games that they're telling me to play. And so, but this deeply matters to our patients, because if you ask a man with diabetes what he's more bothered by, his blood sugar on the test versus his erection not working, if we can fix the diabetes through the things he actually cares about, which is his ability to feel his own penis, I think we'd go a lot farther, right? But they don't even understand that it's the diabetes that makes the erections not work as well. And so it's time. And so again, we are trying to play in a system that is not serving our patients. It's not serving us, right? And so everyone's unhappy, which is why patients are mad and leaving bad reviews. Doctors are mad and leaving medicine, and it's all going to break at some point.
This is a great point. I'm making a note to myself that I need to do a podcast on healthcare reform and, just what needs to change. I think that's such an important topic, but I'll tell you what I do. I end up being honest with the patient. I'm like, you're booked for an annual today, and I want to spend more time talking about this. So let's get through what we need to do for your annual today. And why don't I have you, why don't you do these things? Sometimes I'll ask them to keep a diary or something, and then have them back to have another chat about, so I have more time, which is not the best, but it's an approach.
But it's a really good approach. And I think it really serves well for a virtual visit even, right? Like the ability to even sit, pandemic has taught us the wonderful benefits of virtual care is a patient can be in their own home, in their own space with their own coffee and sit there. And, what I find is people take the day off when they have to go to the doctor for cancer checkups, right? Like that's worth taking a day off of work. Their orgasms don't tend to make them want to take the whole day off and come and all those things, right? So, but to have a virtual visit where you can sit and focus on those issues, I find patients are really grateful for that.
That's a great piece of advice. That's right. So I want to go back to, you talked about the big categories of drugs that often cause sexual dysfunction. And I do want to spend, I didn't realize about Propecia, but that's kind of interesting because I have even female patients get that for hair loss, So it seems like these drugs either affect your hormones or your neurotransmitters. I guess I want to spend a few moments talking about birth control because I'm so passionate about not giving up on birth control. What are your favorite? I know vasectomy, yes. vasectomy or tying your tubes.
Yes. I think the Mirena IUD is a wonderful option for patients, obviously. I think it is, you don't have to think about it. You put it in, it decreases your bleeding. It's birth control. It protects your uterus from any kind of overgrowth. So it's a really lovely option when you can do it. I think more clinicians should be offering it with sedation or, with nitrous or things like that to really make the experience not terrible. Because I think I have a very big interest in medical trauma. And I think there is a whole lot more medical trauma than there is sexual trauma out there. And I think all of our patients have been harmed by nasty words from doctors and nasty experiences in rooms and exam rooms and things like that. And we're not talking about it. We don't take ownership about how much that's causing patients, like dismissing a patient's concern, right? Because you don't have time is actually deeply harmful to the patient who will now never come back to see you again, right?
Or any doctor.
Or any doctor for that matter, right? So we cause a lot of medical trauma. In terms of birth control, right? I always say, pick your poison. It's all poison. And we have to figure out what the best one is for you.
Mm-hmm.
So I think oral birth control pills, again, don't affect everyone the same way. And so I can't say, we don't know the science precisely enough to say, oh, you'll do fine with this oral birth control and this will be a horrible thing for you. So I'd love to see that research extend. There's a very cool medicine called Advocacy, which is a non-hormonal birth control where it's an acidic gel that you put in the vagina right before sex. I give it to my male patients sometimes to carry around with them. So you got a condom and Advocacy and you put it in and then you're doubly covered, right? And so I think it's a great birth control for men and women. You got to use it. It doesn't work if you don't use it. But again, just an added sort of layer for patients. And I don't think we talk about that nearly enough. Mm-hmm. So that's kind of my take. Again, I'm not a gynecologist, so I know I don't prescribe birth control pills.
Yes.
I see so, and I'm very pro not having a child if you don't want one. I'm very pro that, right? And the complications of pregnancy and things like that. And so I think it's a nuanced discussion. I think where I get frustrated is sort of this lack of informed consent that we're giving to patients, saying like, this is good for everybody always, and there are no side effects. And I think when you play with hormones, there are consequences, and we have to be able to say, well, the good seems to outweigh the potential bad, right? You may not have acne, that's good, but what if you have increase in depression, anxiety? That's bad, right? So, and your ability to say, listen, this is what the tools that we have. I'm here with you and we'll navigate it together. Speaks so much better than, oh, that anxiety is not from the birth control pill. There's no possible way, get an SSRI. Because now you're getting all the women that are on birth control and SSRIs. Right? And then you're like,
double
well,
whammy.
Did I cause that need for that? And so we don't take responsibility for that. And we gaslight a lot of people and telling them that it's not us, it's them. And I think that's not always true.
That is a good point. I mean, that's a common combo, which is a double whammy. You're hitting your hormones with a pill or, hormonal birth control and antidepressants.
So I tell those patients, again, those patients come to see me for low libido. And I say, give yourself a damn break, right? Like your gas tank is not only empty, but it is siphoning out any gas that you're trying to give it. Because the birth control pill botches your testosterone levels, right? The SHBG is going to increase. So that may cause increase in sexual pain. The antidepressant is going to lower your dopamine levels. And so and make your libido low. And then you've got kids and a job and all these things and your partner's wanting sex all the time. Give yourself a damn break. The biology is against you. And so that's where we get them to understand the biology and then decide, do we want to tinker with that biology, right? This is why I'm so aggressive, is because I see the future. I see patients who come to see me after getting through all of this and say, I love sex. I'm having a great time. My orgasms are fabulous. I have a libido. I'm killing it at work. My kids are off to college. Now I have a lock on the door and everything is amazing, Dr. Rubin. And I see where they start from. And so again, people often don't have hope. Like they're not bothered by it because they don't even know there's something to do. But I see the magic, and which is why I force patients to really consider all their options and really think through it and decide what is right for themselves. I had a lady this week, I have one of my favorite patients, when she came to see me, or she actually didn't, someone pulled me into the room with her. She was seeing somebody else. They pulled me in the room to look at something on her exam. And we ended up talking, and she said, well, I'm open to doing anything except hormones. Hormones cause cancer and I will never take a hormone. And I said, okay, I would love to talk to you more about this, about what the data really shows. And I'd love to have a really good sit down and have a conversation with you. Over the years, she and I have worked together very closely. She ended up going on hormone therapy. She ended up she has literally the most wildly pleasurable sex life that you could ever imagine. The story gets even more interesting.
Enviable, huh?
It's a wildly interesting story. I hear the best stories, but she never would have done that if I hadn't really forced her to sit down and have a conversation about it. Now she went to law school, right? And is going to become a lawyer because her brain works so much. She's highly functioning. She says, I'm keeping up with the 20-year-olds. I'm kicking ass at law school and doing amazing. And again, I did that because she never would have considered. So I'm saving the world because I'm keeping women in high places doing amazing work by pushing them to consider what actually could it look like if it didn't have to be this way.
Go, Dr. Rubin. That's amazing. I love it. Okay. So I am a gynecologist that does prescribe birth control. And I always like to start with, pregnancy and having children when you're not ready are also libido killers.
Horrible. I agree.
But Yes, we have other options now. We have more options. Like you said, Phexxi. We also have, you mentioned the Mirena IUD, which is much lower hormones than, the pill, but also a non-hormonal IUD. And then there's low hormone birth control and lower hormone pills, for example, and permanent sterilization. But I also think to your point, I think it is a good idea at times. So, in my general feeling is that a lot of women tolerate the pill, myself included. I used the pill for decades and tolerate the pill with minimal side effects. But there are patients that do have side effects. That is not fake or made up; they're real, and so you have to address those. And sometimes, like you said, a drug holiday might be indicated, and then you could really get to your baseline and see, well, this is how I am, is there a problem here or am I good? And then, it was your medication, right? So I guess we can move to the other thing I was thinking while you were telling us the categories of drugs. You mentioned blood pressure medication. And my impression with that is that more that affects more male sexual dysfunction. Does that also affect female sexual dysfunction? Because I don't usually address that. I know about of course, the hormones and the antidepressants or psychotropic meds, but blood pressure medication doesn't automatically trigger in my mind, oh, this could be a problem.
Think through homologs, right? So if it affects the penis, do you think it affects the clitoris?
That's true.
Of course it does. Of course it does. But we don't even care enough about women to study arousal disorders, right? So the research on arousal disorders is about 3 decades behind that of male arousal disorders, right? We know the blood flow to the penis. We look at it, we measure it, we talk about it, we ask about it, we have imaging ways to look at it. And so it's pretty well characterized. Why? Because Viagra came out in 1998 and changed the way we look at the penis. And so again, we're 30 years behind on the female side because the clitoris and the penis are exactly the same things, same blood flow, same muscles, same arteries, same nerves. And so if a blood pressure medicine affects the penis, it of course affects the clitoris in the same way. There's just not enough data to look at it because that's the problem. And again, this is actually a big problem because women are dying of heart disease, right? They are dying of heart disease, much higher rates than breast cancer. Women are dying of heart disease. And in men, we can pick up heart disease early because their erections start to get a little funky. And then we send them to a cardiologist and they get their heart disease taken care of. No one's asking women about their orgasm or their arousal, but I bet you as soon as arousal starts to change, your risk of heart disease is starting to climb, right?
I love that. Oh my goodness. Because so many women come in around menopause saying that, it's harder, their, libido's down and it's harder to get an orgasm, for example.
Yeah.
And
we tell them, what do we tell them? To do a date night. What should we be telling them? Probably to get a cardiovascular evaluation, to take hormones and to use vaginal hormones and that this is a sign of an overall marker for your vascular health.
Yes. I mean, women are so concerned about getting breast cancer, but the number one killer is heart disease, cardiovascular disease. Yeah. So what a good point. And you're certainly helped me think about that too. Asking about patients, often my first question when they start telling me that they're having problems is, okay, what's changed? Did you add any meds? Did something happen? And the blood pressure medications don't strike me as a red flag, but they should.
And that's not me saying don't take blood pressure medicines. I want to be very clear. I'm not saying don't take blood pressure medicines. I'm saying you really need to look at all of those things and really, again, that we use tools. If I have a guy who's on blood pressure medicine and he has erectile dysfunction, sometimes we work with cardiology to change the blood pressure medications around, but then we treat the erectile problems, right? So heart trumps genitals, right? The heart is more important than the genitals, but not by much. And so we got to care about all of it.
Yes, that is the good message. Please do not change anything based on what you hear today without discussing with your medical provider. This is just meant to be educational and hopefully prompt appointments with your provider to talk about what may be concerning you. Do you think doctors talk enough about these side effects? I don't get the impression that they do. And then it's often like me telling them, well, that's a normal side effect, and they're sort of in shock.
It's the short visits, right? Is that we don't spend enough time talking about the side effects and we decide what we think are the more important side effects, right? And we decide which ones to talk about. It's a challenge, right? It's a challenge all around.
Right. So anytime I talk about medications and sexual dysfunction, I'm sure you've seen this online as well. There is a really big advocacy group, or advocacy groups, I should say, that want to talk about SSRIs and sexual dysfunction. I think the post SSRI Sexual
ESSD,
Dysfunction
yeah.
Network, yes, is a very big group. I follow them back, and I think they make a lot of interesting points. Thoughts?
It's a huge problem, and people are suffering. People are really deeply suffering, and our lack of educating mental health professionals on the sexual side effects and making them a part of the discussion on sexual health, the lack of our of talking about that, thinking about that, working with patients on it, it's a huge problem. And so again, by siloing sexual medicine into a tiny thing that's not really, that sex is this private part thing that we don't really talk about or discuss, is just a disaster, because we're giving these medications to kids, we're giving them to young adults, and we're not having conversations with them because, it's not appropriate to talk up to an 8-year-old about possible erection issues or clitoral issues, but then we're giving them, antidepressants, and then not following up when they're teenagers or when they're we feel so deeply uncomfortable having sexual conversations with patients, and it is horrible, right? It's horrible. Mm-hmm. And so the consequences are great, and the level of research and outrage and funding is abysmal. And so I believe, I believe that patient advocates are the things that change medicine. It is because of their advocacy and their unrelenting push to make change happen is actually when we see change happen. And so I'm always on the side of the patient advocates. So I work a lot with these networks, the post-finasteride syndrome groups, the PSSD groups. We see the persistent genital arousal disorder groups. The tight-lipped is a great vulvovaginal pain disorder patient advocacy group. I'm on their medical board. We have to be listening to the patients. And it is that in that listening, we're doing a lot of research on post-orgasmic illness syndrome with the patient advocacy groups. And so unless we incorporate patient voices into our research, into our advocacy, we're missing the mark completely. Because why do we do any of this, right? And so I think we need to take these people seriously and work with them and design research protocols very closely using patient advocates. And our medicines will always hurt people. Medicines and surgeries will always hurt people. And the key is we try to make, the whole point of the FDA is to make sure that the benefits outweigh the risk, right? And there will always be risk. You will never have anything. And there's risks to not doing anything. There's risks to untreated depression, right? And so again, it's really understanding the risks and being able to inform people properly and then study it to say, how can we do better, right? We're always trying to do better. And we have a lot of work to do.
Yes. I mean, so some of the things you talked about there, it is so concerning, like young people are getting it. And the other thing is just how long people are on these medications. That sort of also shocks me sometimes when I take patient histories, like decades, and it's like.
But I could argue if you have a patient with a thyroid disorder, like they're not going to get off their thyroid medicine. If I have a patient with their ovaries are no longer producing estrogen and we decide estrogen's a good choice for you, I want them to take it forever. I never want them to stop it. And so again, similar of how we're talking about GLP-1s and obesity and hypertension, like these sometimes chronic medications are things that need to happen. But again, it is understanding the risks, the benefits, the side effects, and then understanding what do our patients want and care about, because we have to always have this body autonomy of what do our patients care about?
Yes, I think that's a very good point. I was kind of shocked at the size of some of these advocacy groups. So it sort of made me look into how often this problem is happening. And I just, read something like over 50% of patients on SSRIs have sexual dysfunction, which is kind of shockingly large. I mean, do you agree with that number?
There's no shortage of it. That's for sure.
Yes. And some of them also say that it can cause, even if they weaned off, like it can cause permanent dysfunction. How often do you think that's happening?
We don't know. I mean, again, we don't know. And it all depends, again, how things act on the receptors, what issues, what downregulations are happening, what biology is happening there, how it acts on the muscles and the tissue. And so, again, the brain doctors don't talk to the genital doctors. The genital doctors don't talk to the brain doctors. Nobody's talking to it's this lack of discussions and sharing of information. And that's where, again, why I'll plug ISSWSH, the International Society for the Study of Women's Sexual Health, because it truly is a multidisciplinary organization that is deeply trying to understand the science here. And that's, we've got basic science researchers, we've got clinical researchers, we've got gynecologists and urologists and pain doctors. And we're really looking at this from multiple angles, but it's a tiny organization with tiny funding that really isn't really, the NIH level, right? So we have to be doing this a little bit bigger and more loudly.
Thank you. So we probably should wind down, but I want to, I guess one question I have that, maybe someone's listening out there and concerned about maybe a medication they're taking causing this sort of side effect. What is your approach? Besides like when a patient's in front of you, how do you approach a potential side effect? Like what are things you think about as potential things you can do?
Yeah. So again, it's the biopsychosocial understanding of what's going on with the biology. Is it in their brain? Is it in their spinal cord? Is it in the genitals themselves? Is it a hormone problem? Is it a muscle problem? Is it a nerve problem? Is it a dopamine problem? Do we need to change medications around? Do we need to add dopamine boosting agents? We have FDA approved products for low libido that work for people, but nobody prescribes them because they feel like it's not their lane or it's not appropriate or it's all psychosocial and they don't believe in the science. So if we believe that medicines can hurt sexual function, which we just talked about for a long time, could medications help sexual function? Of course they can. If you boost the opposite receptors on dopamine, you're going to help sexual function. So things like Addy and Vyleesi and testosterone all work with sexual function. Like everything, do they help 100% of people? No. But do they help significantly over placebo? Yeah. Do I see them help people every single day with sexual function? Yeah, I do. But when we only have 10 minutes and we're focused on the pap smear, we're not even going to play with those medications because we don't think it's our lane or our responsibility to do. And so that becomes, well, whose responsibility is it to try to help these patients? Because again, the mental health people aren't talking about sex. The gynecologists you just said aren't talking about sex. And so who is helping tinker and play with these medications for the patients? And that's where it becomes really important to teach and educate and give people the tools to say, how do we play with these medications in our toolbox and decide which is the right ones for my patients? And my patients deeply understand that I don't have a magic pill for everybody, but that we're going to have a toolbox that we're going to work with to say, let's try this, and then we'll add this, or we'll subtract this. And just like your ovary makes estrogen, progesterone, and testosterone, it's not one thing. Oftentimes, it is going to be a toolbox of things that is going to make you feel like you and like your best self. So in menopause, I often give patients whole body estrogen, progesterone, testosterone. I may give them local therapies to prevent UTIs, and I may give them dopamine boosting agents to help with their libidos. And just like in your shower, you've got shampoo and conditioner and body wash and your razor and your shave gel, right? In menopause, you may have a toolbox of, okay, my ovary's not working anymore, so I'm going to take all these different things to help support me. And so it becomes understanding that deeply. And then you don't feel like, oh, I'm taking so many medicines, I'm old and creaky. In fact, we use these medicines so that you won't need blood pressure medications, depression medications, and all these other medications down the road. But we're not thinking about that prevention. We're not thinking about supporting the patient in front of us. We're thinking whack-a-mole of when problems come up. We just, deal with them when they arise. Does that make sense?
Yes. Thank you so much, Rachel, for your thoughts. This has been such a good experience for me too. I've learned. I appreciate it.
Thank you for having me.
Oh, you're welcome. Please come back someday. Can you please share with my audience where they can find you on your socials if they want to hear more of your thoughts?
Absolutely. First, sign up for our newsletter. We don't spam you, but we send a lot of really educational articles and things that are going on in this field. RachelRubinMD.com is how to sign up for our newsletter. And then all my social media channels are at Dr. Rachel Rubin, and I'm sure they'll be posted there. And I would love for you to follow me, and just grateful for the work that you're doing.
Thank you so much. Okay, so I always leave with a closing thought. And my thought for today was that I feel that the patriarchy does not consider women's sexual health a priority. But in the Gynarchy, we do know it is a priority. It's very important. It's an important facet of women's overall health. So down with the patriarchy and up with the Gynarchy. So I hope you have a wonderful day, Rachel. Thank you for joining me.
Thanks for having me.
Did you enjoy this episode of the Gynarchy Podcast? Know someone else that might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Twitter, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.